Hello friends. So we are continuing with the part 2 of the December 2025 NEET-SS Medical Onco Recall. So next question is continuing from where we left off in the part 1. The question is regarding OCP use and cancer relationship. These four are the options that they had given, at least roughly what they have given. I think what we need to know to solve this question is pretty much simple. OCPs generally increase the risk of breast cancer by 1.2 to 1.3 times. I mean, that is the relative risk increase is 1.2 to 1.3. So OCPs increase the risk of breast cancer, the relative risk being 1.2 to 1.3. Whereas OCPs usually protect against ovarian cancer. OCPs protect against ovarian cancer, but increase the breast cancer risk. Now, point number 2, this is largely applicable to pills that contain estrogen and progesterone. Progesterone only pills don't have much of an impact on either a causative or an increased incidence risk on breast cancer, neither a protective effect on ovarian cancer. So, both ways, the impact of progesterone only pills is less. The increased risk of breast cancer and the protective effect on ovarian cancer are more with the combined OCPs. The newer OCPs, which have relatively lesser amount of estrogens, they cause less increased risk of breast cancer, but they give almost equal protection to ovarian cancer. So, OCPs in general protect against ovarian cancer, mildly increase the risk of breast cancer. The newer OCPs with lesser estrogen, along with usual progesterone, their deleterious impact on breast cancer is relatively less but still present. They also do protect against ovarian cancer. Progesterone only pills do not have much of an impact as much as the combined pills. So, the answer here would be B, the reduced incidence of ovarian cancer by 10 to 12% after 1 year of use would be the answer to this question. Moving on to the next question. It says the Oncotype DX score is 16. What to do next? So when we don't have the complete clinical picture as such here, we'll just look at the common points. So Oncotype DX, is used for patients who have ideally a node negative disease or also up to N1 node, that's up to 3 involved nodes after surgery. Patients are having a strong ER/PR positivity and a HER2 negative breast cancer, hormone positive, ER positive, HER2 negative breast cancer after surgery. Of course, if it's a N2 disease, that's more than 3 nodes are pathologically involved, that patient definitely warrants chemotherapy. Patients with N0 disease or N1 disease, that is up to 0 nodes or up to 1 to 3 nodes involved, they can get away without chemotherapy. So how do you choose those patients? There are various methods. The most approved one is Oncotype DX. Based on Oncotype DX, you stratify patients, and patients who fall into low risk, who have T1 or T2 or even T3 disease with up to 3 nodes positive. So these group of patients, if they have low risk on Oncotype DX, they can safely omit chemotherapy. They can take only hormonal therapy. So ideally, it's for T2 N0 disease, but then it has been expanded. It's also the guidelines now also include patients with T3 disease and also patients with up to 3 nodes involved. So up to T3 N1 is theoretically possible. We can depend upon Oncotype DX to omit chemotherapy. So up to T3 N1 disease, hormone positive, HER2 negative, you can look at Oncotype DX, and low risk you can omit, high risk you have to give chemotherapy. T4 or N2 diseases definitely need chemotherapy. So that's the basic point. The important thing to really look at here is that in the premenopausal age group who are node positive, this is Oncotype DX can still be used, but it is not in the preferred category in the NCCN. Okay, So ideally, oncotype DX can be employed in patients who are up to T3N1 disease, number one. But when it comes to premenopausal patients, if the nodes are involved, there is a usual clinical preference to give chemo anyways. So premenopausal node negative oncotype DX is equally acceptable, but premenopausal node positive diseases, we can still use oncotype DX, but the practical use of oncotype DX or the preference to use oncotype DX relatively comes down, because the clinical preference is to probably give chemotherapy anyways in the premenopausal age group if the nodes are involved. So postmenopausal up to T3N1, you can use oncotype DX to stratify and decide on whether to give chemo or not. Premenopausal also up to T3N1, you can use oncotype DX to stratify and decide whether chemo can be given or not. But premenopausal node positive, the usage or implication or the preference to use oncotype DX comes down a bit. What are the other methods that are less used compared to oncotype DX? We have got the 70 gene mama print assay, the 70 gene mama print assay, the 50 gene Procina, the 12 gene endopredict. So the mama print, which is 70 gene, Procina, which is 50 gene, 12 gene endopredict. These are all the other tools that can be used for similar purposes, but they are not as validated or as preferred as oncotype DX. Oncotype DX remains the standard of care when it comes to this. Another one is breast cancer index, of course. That is, so the oncotype DX, the 70 gene mama print, 50 gene Procina, 12 gene endopredict, and the breast cancer index can all be used in this context, but the most preferred is oncotype DX. The oncotype DX value has got prognostic, the oncotype DX score has got prognostic value and predictive value. So a low score on oncotype DX means that they have a good prognosis. The predictive value is, if the value is less, you can skip chemotherapy more safely. The other assays like the mama print, endopredict, Procina, etc., they have prognostic value, meaning less value, the low risk in that means less chances of recurrence in the future, but they do not automatically tell you that you can exclude chemotherapy. So they have less predictive value from a therapeutic point of view, but they have good prognostic value. That I'm talking about mama print, Procina, and endopredict. They have prognostic value but less predictive value. Oncotype DX has got both predictive value and prognostic value. The breast cancer index has got prognostic value, of course, but breast cancer index, there is some therapeutic value. That is, patients who are having a higher risk on breast cancer index will benefit from extended adjuvant hormonal therapy. In that sense, BCA has got some predictive value. So I'm just talking about oncotype DX here because this is a recall. I cannot discuss everything, but make sure that you know about mama print, Procina, endopredict, etc. Refer to our parent modules also for more information. So here the question is oncotype DX score of 16. What is the next step? So this is what you can generally say in postmenopausal, okay? In postmenopausal, an oncotype DX final score of less than 26 means you can give only hormonal therapy. A score of more than or equal to 26 in this patients means you have to give chemo plus HT. HT stands for hormonal therapy. When it comes to the premenopausal individuals, there is a slight change. We can divide it into, I think we'll just kind of go a little more, we'll keep it more open-minded. I'm not getting into too much complexities there of N0 and N1. Premenopausal in general, you can say a score of 15 or less is one category, a score of 16 to 25 is another category, and a score of 26 or more is another category. So 26 or more definitely needs chemo plus hormonal therapy. Less than 15 does not need chemo, they need only hormone therapy. 16 to 25 category, the benefit from adding chemotherapy is less, but it is still there. So you can go hormonal therapy plus minus chemo, but in clinical practice, there is a preference to give chemo in this category as well. So when the oncotype DX is 16, okay, when the oncotype DX is 16, in a postmenopausal female, if the oncotype DX is 16, the answer is very, very simple. You need to give only hormonal therapy. In a premenopausal patient who is having an oncotype DX score of 16, hormonal therapy is definitely required. The addition of chemotherapy is 50-50. You can add, but the benefit is not really great. So premenopausal, 15 or less, only hormone therapy. 26 or more, chemo plus hormone therapy, no issue. Premenopausal oncotype DX score of 16 to 25, hormonal therapy definitely needed. Chemotherapy can be added, but the benefit is relatively less. So here, to give the right answer to this question, we need to know the complete detail, including the menopausal status. But if it was a pure blank question without mentioning the menopausal status, I think you will have to choose hormonal therapy alone, because for the postmenopausal group, oncotype DX of 16 means hormonal therapy alone. For the premenopausal group, hormonal therapy alone is an option because chemo is optional in this group. So I hope the question had the menopausal status also clearly mentioned. If not, we will have to go for hormonal therapy alone. So forget about the question, understand these facts very clearly. The next question is, this is quite an easy question. The pancreatic head tumor with the patient with pancreatic head tumor, we are assuming it's adenocarcinoma. It encloses SMA by more than 180 degrees. So they are basically asking whether this is resectable, metastatic, borderline resectable, or unresectable. So I think what is borderline resectable? So by borderline resectable, you basically mean the superior mesenteric artery is less than or equal to 180 degree abutment. Okay, so we can say borderline resectable means SMA abutment is less than or equal to 180 degree. Okay, likewise celiac axis also less than or equal to 180 degree. SMV or portal vein is involved but reconstructable. So these are the criteria when you say that it is borderline resectable. So SMA encasement or SMA abutment is there, but the abutment is 180 degree or less. Celiac axis abutment is there, but it's 180 degree or less. Portal vein or superior mesenteric vein is involved, but it is reconstructable. So in these situations, you called a pancreatic head tumor borderline resectable. If none of these vessels are not involved and there are no mets, definitely that is resectable. If these vessels are involved in as per this criteria, it is borderline resectable. When is it frank unresectable? It's frank unresectable when superior mesenteric artery is more than 180 degree encased. As in this question, it encloses SMA more than 180 degree is frank unresectable. Likewise, SMV or portal vein involvement that is not reconstructable is also frank unresectable. Total encasement of celiac axis. So what is mentioned in the question of SMA more than 180 degree plus or other than that, the other, so SMA involvement or enclosement more than 180 degree means unresectable locally advanced pancreatic cancer. Also, complete celiac axis encasement or involvement of superior mesenteric vein or portal vein which is not reconstructable are also clearly totally unresectable pancreatic head tumors. Here the answer is hence C. Moving on to the next question. This is a direct hematology question, so I'm sure this would have been discussed in our hematology modules. You are giving intrathecal methotrexate. Probably we are talking about an ALL case here. The platelet count is 20,000. What should we do? So for this intrathecal methotrexate, we should be having a platelet count of 50,000. So what are the options that we have? Correction, abandon, only lumbar puncture. We should correct the platelet count, increase it up to 50,000 and then do the procedure. So correction followed by doing the procedure is the right answer. abandoning, immediately you abandon, but you correct and try to do it with the appropriate platelet value. So I would choose correction as the answer. The next question is pleuroperitoneal myxoma management. Uh, this might have been pseudomyxoma peritoni, the question, in which case the answer is cytoreductive surgery and HIPEC. In pseudomyxoma peritoni, which is, as you know, the jelly belly appearance of the abdomen, epithelial tumors arise in the appendix or the ovary, mucinous tumors, they spread like this jelly thing across your abdomen, across the patient's abdomen. The only real treatment being complete cytoreduction followed by HIPEC, that is pseudomyxoma peritoni. Here they have asked for pleuroperitoneal myxoma. So pleuroperitoneal myxoma is actually a benign tumor, not something we deal with consistently, because as oncologists, we don't need to treat much of these benign tumors, at least from medical oncology point of view. Pleuroperitoneal myxomas, if they are asking for management, the management is always surgery. Pleuroperitoneal myxomas are benign, hypoplastic, very less cells, mesenchymal tumors, which can be seen in relation to pleura or the peritoneum. They are benign tumors. They do not respond to chemotherapy or radiotherapy. The treatment is always aggressive resection. I hope we get more details about this question at some time in the future, so that we can discuss this topic in greater detail in another video. But for the time being, the management of this disease is always surgery. It's a benign tumor. It's a mesenchymal tumor, relatively low grade hypocellular tumor, which occurs in pleura and peritoneum, as the name suggests. This question again, I don't really understand the answer. Post-menopausal woman requiring ovarian suppression therapy is the hint I got. Post-menopausal woman does not require ovarian suppression therapy because this woman is already post-menopausal. So basically, premenopausal women with CA breast who have high-risk disease, they benefit from ovarian suppression therapy by using leuprolide. In those patients, we convert these premenopausal high-risk patients. Initially, we give tamoxifen because tamoxifen works in both premenopausal and postmenopausal people. So we initially give tamoxifen, then we induce menopause by giving in premenopausal patients, we induce menopause by giving ovarian function suppression with leuprolide usually, or any other kind of ovarian function suppression like ghrelin. All of those molecules can be used. So once the hormonal milieu has been changed into postmenopausal status, then you switch the patient from tamoxifen to aromatase inhibitor, which is anastrozole or letrozole. So that is where we practically use premenopausal. Even high risk CA breast, we convert the premenopausal milieu into postmenopausal milieu by using ovarian function suppression. We can use GnRH agonist or antagonist. You can do oophorectomy or even ovarian ablation using radiation to induce postmenopausal status, and then switch from tamoxifen to aromatase inhibitor letrozole. That is the theory part, but the question is not complete, so we cannot really answer that question. This is a very simple question. Primary peritoneal carcinomatosis, or PPC, is treated equivalent to, I think it's quite easy. Primary peritoneal carcinomatosis is treated equivalent to high-grade serous ovarian carcinoma. I think that's something we have discussed in detail. Primary peritoneal carcinomatosis, you should know the diagnostic criteria of primary peritoneal carcinomatosis. There may not be a clear ovarian mass that is made out, but there is extensive peritoneal disease. There is a clear diagnostic criteria which you need to know, and they usually do have a high serum CA 125 as seen in serous carcinoma of the ovary, and the treatment is quite similar to serous carcinoma of the ovary. The next question is retinoblastoma familial, both eyes white reflex. I did not have enough details of this question to give you an answer, but I understand this is quite a very straightforward question from retinoblastoma. As I told you in the previous video, this retinoblastoma, neuroblastoma, nephroblastoma, hepatoblastoma, or rhabdomyosarcoma, Wilms tumor, probably there's just 5-6 of these common blastomas and pediatric cancer. They have been well covered in our modules. Please go through them. The questions are directly from what has been taught in the modules for these blastoma tumors. Please make sure you know them thoroughly, and then you can have the answers to them quite easily. We had one question on Roma score. Usually not very commonly asked, but then they have chosen to ask. Again, discussed in our modules is what I believe. Roma score is basically, I think, ROMA stands for risk of ovarian malignancy algorithm. Risk of ovarian malignancy algorithm. So, when you have an ovarian or an adnexal mass on imaging, if you want to pre-operatively or before biopsying or doing a surgery, if you want to, assess the uh, potential for it being malignant, there are various methods. You can go by your clinical methods, you can go by radiological method. One score that is used for that is the ROMA score for assessing pre-operatively. So, of course, in ovarian tumors, you know that ovarian tumors, if they are being planned for neoadjuvant chemotherapy, so if they're advanced, multiple peritoneal mets, if the tumor is fixed, if the upfront cytoreduction may not be optimal, in those cases, you take a biopsy and then give neoadjuvant chemotherapy and then do surgery. Whereas in early tumors, which are clearly operable, you can directly take those patients up for surgery, because in those patients, if there are no peritoneal mets, if there are no omental mets, by taking a biopsy, you might actually cause omental and peritoneal spill and upstage the tumor. So in isolated adnexal masses, you which do not warrant neoadjuvant chemotherapy, you will upfront take up those patients for surgery. So in those cases, it's important that the surgeon has an idea whether you're taking up the patient is a malignant tumor or a benign tumor. This is usually, of course, has to be decided by a frozen section during surgery, by intraoperative findings. But before surgery, there are various ways of predicting the malignant potential in these kind of cases, because you're going in without a biopsy mostly. There are radiological criteria which we have discussed in great detail in our modules, benign versus malignant radiological criteria. Another tool that is used is the ROMA score, risk of ovarian malignancy algorithm. It employs the CA 125 levels, serum HE4 levels, human epididymis protein 4. HE4 is human epididymis protein 4. CA125 is the famous lung ovarian cancer marker that you know, and the menopausal status. So HE4 levels, CA125 and the menopausal status are taken into consideration. In patients who are premenopausal, a score of more than 13 is high risk, and in postmenopausal, a score of more than around 27 is considered to be high risk for malignancy. This is basically an algorithm for deciding whether an adnexal or an ovarian tumor is malignant or not. CA125, HE4 and menopausal status are used. In premenopausal patients, a score of more than 13 is considered high risk of malignancy, whereas in patients who have a postmenopausal status, a score of more than 27 is considered to be malignant, high risk of malignancy. Moving on to the next question. Again, we don't have much details about this question, but we have covered sarcomas in great detail. This is a good question. Squamous cell carcinoma, lymph node mets, unknown primary management. So basically, I think it looks like I am understanding that we have a case where we are looking at a patient with a cervical lymph node, which on biopsy turns out to be squamous cell carcinoma. How do you manage? So, if there is a squamous cell carcinoma deposit in the neck, so the assumed primary is always head and neck cancer, oral cavity, oropharynx, larynx, hypopharynx, or the nasopharynx. It can also be upper esophagus, the esophagus, or the lung also. Okay, so of course the level of the lymph node, whether it's supraclavicular, right supraclavicular, left supraclavicular, can all have implications. For example, left supraclavicular will point more towards maybe a lung or an esophageal primary, maybe left supraclavicular. The right supraclavicular will probably less likely to be esophageal. It can be lung, it can also be anywhere of your head and neck cancers. So basically, if you have a cervical lymph node biopsy showing squamous cell carcinoma, you have to figure out the primary with an extensive investigation. You should do a extensive imaging, preferably a PET scan, look for a primary. You can do a proper ENT evaluation. You can do a proper ENT evaluation, including scopies. We should do what is called a pan endoscopy, that is, all ENT scopies should be done. Nasopharyngoscopy, nasoscopy, diagnostic nasal endoscopy, they should all be done. There should also be a bronchoscopy and an endoscopy done. So this is to look at the esophagus, lung, and the whole of the head and neck areas, and then try and figure out a primary. So if you get a primary, if you get a clear primary, you treat the primary as you see. So if it's an esophageal primary, you treat the esophageal primary. So if you get a esophageal primary, you treat it is as a CA esophagus. If you get a lung primary, you treat it as CA lung. So that's quite easy. So I think here the question, we don't have the full question. We do have the question. It clearly says unknown primary. So here the question says it's a squamous cell carcinoma lymph node. So probably a cervical lymph node, of course, a cervical lymph node, squamous cell carcinoma. The primary could not be made out despite a proper evaluation, including a PET and multiple endoscopies or the pan endoscopies. In that case, what do you do? The answer is usually chemo radiation. Unless if it's a single neck node, you can dissect it. You can have a nodal dissection followed by radiation. But usually a single lymph node is very unlikely. It's likely to be multiple lymph nodes. And in that case, the treatment is concurrent chemoradiation. Just like the concurrent chemoradiation that you give for your head and neck cancers, you treat these patients with extensive radiation and weekly chemotherapy of cisplatin, preferably at 40 milligram per meter square. If the patient is cisplatin ineligible, you can other molecules, but mostly we use carboplatin at an area under the curve of 2. Other drugs like cetuximab have also been tried in this milieu, but the classical teaching would be concurrent chemoradiation with weekly cisplatin. The exception being a single isolated node where you can do a surgery and then give an adjuvant RT, but that's a very, very unlikely scenario. So I don't have the options to this question, but I am thinking the answer here would be CCRT, that is concurrent chemo radiation, chemo plus radiation, the chemo being weekly cisplatin. The next question is secondary cancers after Hodgkin lymphoma. The question, we don't have the detail of the question again, but yes, the most common cause of late mortality in a patient who has been cured of Hodgkin lymphoma is second malignancy. So if they ask you the cause of late mortality in a patient who has had Hodgkin lymphoma and survived, what is the cause of late mortality? It is not the relapse of Hodgkin lymphoma, because the relapse of Hodgkin lymphoma is usually rare, and even if it happens, is usually well managed. Effectively, the cause is usually the cause of a late mortality is usually a second malignancy. So, Hodgkin lymphoma is curable, long survival, and the treatment does involve radiation and use of alkylating agents, and it is these two factors that mostly lead to second cancers later on. Now, of course, the patients who are being treated now are much less likely to be diagnosed with secondary cancers later on. The secondary cancers that we now see in our practice are mostly from Hodgkin lymphoma that were treated a few years back. The treatment is being greatly refined. A lot of de-escalation protocols are there. We are giving minimum treatment for maximum cure. So we can strongly hope that going forward, second cancers from Hodgkin will be less. But as things stand, the second cancers occurring after Hodgkin lymphoma, the treatment that occurred maybe 10 or 20 years back, we are seeing in our practice now, and hence this is a clinically relevant question. When it comes to solid organ malignancies, I think the most important thing to say here would be the breast cancer, especially for women who have had radiation to the chest wall prior to 30 years of age, especially the mantle field radiation, that is no longer used. Really, the old mantle field radiation used to confer higher risk of breast cancer. Breast cancers, like most solid organ cancers that occur after Hodgkin lymphoma treatment, they occur after a prolonged interval. The latent period is usually 15 to 20 years. Around 20 years after treatment is when they get solid organ cancers. The most important solid organ cancer being breast cancer in females. the latent period is around 20 years. The guideline says that patients who have had radiation, especially for Hodgkin lymphoma, should start screening for breast cancer 8 years after radiation. The peak incidence of breast cancer after Hodgkin lymphoma treatment is at around 20 years after treatment. What are the other solid organ cancers that can present as a late complication after Hodgkin lymphoma treatment? We can have lung cancers, there can be GI cancers like rectal and colon cancers, there can be skin cancers. It's important to note that melanoma is less commonly seen amongst these skin cancers. It's mostly squamous cell carcinoma of the skin or basal cell carcinoma of the skin. In this setting, melanoma is quite rare. Thyroid cancers are also not uncommon. The most common thyroid cancer amongst Hodgkin lymphoma survivors is papillary carcinoma of the thyroid. The most common thyroid cancer in Hodgkin survivors is PAPCA, but overall the most common solid organ malignancy is the breast cancer. For all solid organ malignancies, there is a relatively long latent period of up to 20 years. When it comes to hematological malignancies, the latent period is less. For hematological malignancies, the latent period is around 5 to 10 years after treatment. What we usually see is therapy-related AML or therapy-related MDS. The classical chromosome association, of course, being chromosome 5 or 7 anomalies. So, chromosome 5 or 7 anomalies, shorter latent period, that's around 5 to 10 years. The most common hemat malignancies being therapy-related AML or MDS. Again, this is now quite rare. It used to be more earlier when the treatment regimen was MOPP with large amount of alkylating agents. Now with ABVD and other newer agents coming up, secondary hematological malignancies after Hodgkin lymphoma has drastically come down. Non-Hodgkin lymphoma can also occur as a second primary in Hodgkin lymphoma survivors. I have seen cases of NHL after HL, but that's again quite rare. Moving on to the next question. The question is quite clear. SCGA in TS causing seizures. So what is SCGA? It is subependymal giant cell astrocytoma. So subependymal giant cell astrocytoma is exclusively seen in TS, that is the tuberous sclerosis. TS here stands for tuberous sclerosis. SCGA is your subependymal giant cell astrocytoma. It's seen in children exclusively in tuberous sclerosis. SEGA arises from the foramen of Monro. That is another important question. SEGA arises from the foramen of Monro. Arises from the foramen of Monro. Small tumors that are asymptomatic can be observed, but symptomatic or growing tumors or symptomatic, the most common symptom being seizures, also hydrocephalus. So probably we are looking at seizure, that is symptomatic SEGA. The treatment of choice is everolimus. Everolimus, we know, is an mTOR inhibitor used in various treatments in oncology like neuroendocrine tumors, breast cancers, etc. SEGA causing seizures, that is in tuberous sclerosis, the treatment of choice first line is everolimus. When do you use surgery? Surgery is used when everolimus fails, or if there is an acute life-threatening emergency like an acute hydrocephalus where you have to surgically intervene, then you can use surgery. Otherwise, for seizures, the first-line treatment is everolimus. It's a new concept. It's an important question, a good question. And SEGA arises from the foramen of Monro. The next question is about seminoma post high inguinal orchidectomy. It says lymph nodes LNS plus. I'm thinking it's lymph nodes plus. I think I didn't get a hang of the question. I didn't really understand what they meant by the question. What is the catch of the question? And the options also seem to be a little weird. Radiotherapy, chemotherapy. I'm not sure how to address this. But seminoma management, non-seminoma management has been dealt with in excruciating great detail in our modules. They are very, very important. Once you know them, answer to this question is going to be very simple. Please make sure that you know them and that you remember them and that you revise them. Another question is stage 3 nasopharyngeal cancer. Post radiotherapy, nodes are PET negative. What next? I think the answer is observation. I think the earlier question with regards to Epstein-Barr virus and nasopharyngeal cancer, we had discussed the management of nasopharyngeal cancer in a quick way. It's also, of course, well discussed in our modules. But once the PET is in remission for stage 3 nasopharyngeal cancer after chemoradiation, it's usually observation. I don't think there is anything else to do. So the next question with the proper option is this. The strongest risk factor, I think the earlier question was about management of oral cancers. We don't have the question. But again, management of oral cancers is usually upfront surgery followed by adjuvant chemo or adjuvant radiation or chemo radiation. There are specific indications for adjuvant RT, specific indications for adjuvant chemo RT. What is the adequate margin for oral cavity? We are coming to that. Also, now there is role for in oral cavity, resectable oral cavity cancers that are PD-L1 positive. There is role for neoadjuvant or perioperative pembrolizumab followed by surgery and adjuvant pembrolizumab and adjuvant chemo RT as may be required. But again, I don't have a question to discuss here. Here the question is, what is the strongest risk factor for breast cancer? It's kind of a tricky question. The question is really looking at a population point of view for breast cancer per se. So then option B kind of rules out, because that's for an individual patient. Once there is already a breast cancer, there is a risk of second malignancy in the breast cancer. But that is not what the question is asking for. It's looking for a risk of breast cancer overall. So the strongest risk factor for breast cancer would be a strong family history. Family history increases the risk of breast cancer by around 2 to 3 times if the family history is in a first degree relative. So a first degree relative with breast cancer increases the lady's risk of breast cancer by 2 to 3 times. That is very significant. That will be the answer here. Nulliparity, it does increase, but by around 1.3 to 1.5 times relative risk. Obesity increases the risk in postmenopausal females. In premenopausal females, obesity might actually have a protective effect or a neutral effect. This is something we have discussed in our breast cancer modules. The next question is teratoma in males, benign or malignant? Teratoma in males is always malignant. We don't know how the question was framed. But again, one more question from the germ cell tumor category. Very, very important topic, germ cell tumors. We have got extensively covered everything in our modules. Please make sure you go through them because these are direct pick from those topics. Thyroid question, a lot of questions we already discussed in the previous part of the recall and this part. MEN2 we will discuss in the end because there have been quite a few questions regarding MEN2. Again, another question on oral cavity malignancy. Everything is discussed in our modules. The treatment is usually upfront surgery. There is clear indications for adjuvant RT, clear indications for adjuvant concurrent chemo RT that they have to study those from our modules. Also understand that there is now approval for perioperative or neoadjuvant pembrolizumab, perioperative pembro, that's pembro given before and after in patients who are having PD-L1 positive, even if the primary tumor is resectable. There is another question on trastuzumab resistant breast cancer. So we don't have the question. If it's a metastatic breast cancer that is resistant to trastuzumab, we have got a lot of options now. We have got options like trastuzumab deruxtecan, trastuzumab deruxtecan, TDM1, or previous molecule of trastuzumab emtansine, TDM1. We can use lapatinib, usually with capecitabine. We can use tucatinib. So these are all newer anti-HER2 molecules that are coming up. Addition of pertuzumab, that is they're usually used along with trastuzumab, in trastuzumab resistant breast cancer may not be useful. So patients who have resistance to trastuzumab, adding pertuzumab may not be useful, but patients who have had a good response to trastuzumab, maybe you can later on add pertuzumab. So it's like if you have used trastuzumab in the adjuvant setting without pertuzumab and the recurrence occurs later, you can use pertuzumab. But immediate recurrences for patients who used trastuzumab in the adjuvant or neoadjuvant setting, less than 6 months, adding pertuzumab will not be helpful. You have to go in for ideally trastuzumab deruxtecan, which is the drug of choice now. The drug of choice in trastuzumab resistant cases now is trastuzumab. The drug of choice in trastuzumab resistant cases now is trastuzumab deruxtecan theoretically, but practically there is the issue of high cost. There is also a fear of pneumonitis, as we have discussed in various other sessions. But the best results are for trastuzumab deruxtecan, the other options being cheaper, more experienced in our use, TDM1, lapatinib, tucatinib. These are the options. Next question, the question is about vocal cord fixed in a T3 subglottic cancer. So, vocal cord fixed means a T3 disease. What else is T3? Vocal cord fixation is T3. Paraglottic space invasion. Paraglottic space invasion is T3, and erosion of the inner cortex of thyroid cartilage is also T3. So, vocal cord fixation, erosion of the inner cortex of thyroid cartilage, and paraglottic space invasion are all T3. So, patients with T3 subglottic cancer, the treatment, one word answer would be concurrent chemoradiation. Of course, if there is bulky N2, significant nodal burden, high nodal burden, large nodal tumors, you can use induction chemotherapy followed by radiation. But overall, if you look at it for T3 tumors, concurrent chemoradiation is the answer. When do you use surgery? So, what are the situations in which you would use a surgery for a subglottic cancer? So, T4A tumors, you have to use surgery. Likewise, if there is gross thyroid cartilage destruction, gross thyroid cartilage destruction, you have to go for surgery, that is total laryngectomy. Or if poor laryngeal function, which means there is recurrent, it's basically become useless. So, which means if the vocal cords are already destroyed, not fixed, if the vocal cords are destroyed, it's not salvageable. If there is recurrent aspiration leading to life-threatening aspiration pneumonia, basically a redundant larynx, in that case also you can do surgery. T4A, you have to do surgery. Gross thyroid cartilage destruction, you have to do surgery. Otherwise, treatment is chemoradiation. So, here the answer would be concurrent chemoradiation. The next question, which chemotherapy requires central line? So, they are basically asking if there is a difficulty of venous access in a vesicant drug. That is where central line becomes very, very important. So, ideally for giving epirubicin, methotrexate, carboplatin, ipilimumab, you just need a peripheral line, right? You need not have a central line. But if there is multiple infusions planned and if there is a risk of difficult venous access, central line becomes most important when the drug is a vesicant, and here anthracyclines are vesicant. The only vesicant that is mentioned here is epirubicin, and hence the central line, that is, preventing extravasation, preventing extravasation becomes most important for vesicants, and hence the answer here is epirubicin. So, make sure you know which are the vesicants and how drug extravasation is managed. We have discussed that in our modules. Please make sure that you know the answer to them. We had a question on Wilms tumor histopathology. We don't have the question. I think all of you know the basics around Wilms tumor histopathology. It's triphasic tumor, right? It's a triphasic tumor. What are the components? It can have a blastemal component, epithelial component, or a stromal component, and a stromal component. Blastemal, epithelial, stromal. Blastemal, epithelial, stromal, BSE. Bombay Stock Exchange is for how I used to study, BSE. They are the three triphasic components of Wilms tumor biology. The blastomal component gives it the small round blue cell field, the blastomal component. More the high amount of blastomal component or the persistence of blastomal component after chemotherapy means the tumor is more aggressive and poorer prognosis. So blastomal is the small round cell and the more aggressive part. Anaplasia is an important prognostic factor. Focal anaplasia is a moderately bad factor. Diffuse anaplasia is a very bad prognostic factor, and anaplasia is bad, and anaplasia is usually associated with P53 disease. So these are the salient features about histopathology of Wilms tumor. Of course, maybe they could have asked about nephrogenic rests, the nephrogenic rests, which are the precursor lesions for Wilms tumor. We don't know the question. Again, another good question from pediatric oncology. Moving on, the next question is about quite a tough question, if really. Young child, medullary thyroid cancer, 1 centimeter mass, right lobe of thyroid. The catch here is the M918T mutation germline. This is the RET. I'm sure they would have mentioned RET. This is the subtype of RET mutation that is seen in men 2B. So it's quite tough. I mean, you would all study that men syndrome has got germline RET mutations. Here they are asking what is the exact type of RET mutation seen in men 2A and men 2B. So here it is M918T. So when you see M918T, that is a type of RET mutation. You have to identify that this is seen in men 2B. So once you get this, then it's quite easy. So patients with men 2B should undergo total thyroidectomy, preferably before 6 months. But if there, of course, thyroidectomy in such a young infant can be problematic at times. So at least before 1 year of age. So here the answer is clearly option B, at least before 1 year of age. So men 2A, what is the RET mutation involved? It will be RET 394, and men 2A patients should undergo surgery before 5 years of age. Here the answer is B, because the question is about men 2B. How do you identify it's men 2B? It's by looking at M918T. Quite a tough question, I have to say. What about patients with familial medullary cancer, medullary thyroid cancer syndrome, FMTC, familial medullary thyroid cancer syndrome? Those patients should undergo surgery by 5 to 10 years, within 5 to 10 years. The next, we will discuss MEN2 in little more detail at the end. This is about, again, a hematology pediatric onco question here. So 821 translocation. 821 translocation, that is the involving the RUNX1. So the involving the RUNX1 821 translocation is what you call usually in your AML M2, acute myeloid leukemia M2, and as you would have been taught in the hematology modules, AML M2, the 821 translocation has got a favorable prognosis, which around, I think the 10-year survival rate is 60-70%. Complete response to chemotherapy is almost, if I am right, around 90%. 821, they're clearly looking at the 821 mutation of AML, is what was classically called the AML M2. They've got a good prognosis. Moving on to the next question, which is the CNS penetrating anti-HER2 tyrosine kinase inhibitor. It's quite discussed many times we have earlier. Lapatinib does have good penetration, but the TKI with maximum penetration is tucatinib. So all these newer molecules, that is trastuzumab deruxtecan, TDM1, both are not TKIs, but TDM1 and trastuzumab deruxtecan are ADCs, that is antibody drug conjugates. Those two, they also have good CNS penetration. Tucatinib and lapatinib also have good CNS penetration, but classically the TKI with highest CNS penetration among anti-HER2 agents is tucatinib. That's very, very important to know. We have discussed it earlier also. This question is about which human papilloma virus is associated with oropharyngeal carcinoma. I think the answer is quite clear. 16. So HPV 16 more than 18, and the other strains being 31, 33, 35. So almost 90% of oropharyngeal cancers caused oropharyngeal almost 90% of oropharyngeal cancers that are caused by HPV are due to HPV 16. The other strains involved being 18, 31, 33, 35, etc. HPV 6 and 11 are causing only benign lesions. They don't cause oropharyngeal cancers. So here the answer is 16. The next question is, which bisphosphonate is used in renal compromised? So the most commonly used bisphosphonate is your zoledronic acid. There is a nice trap here. The option A is denosumab. Denosumab is not a bisphosphonate. Denosumab is used for the same purpose. It's a rank ligand inhibitor. Denosumab is acting on the rank ligand. It is not a bisphosphonate. Has got similar use, very similar indications. Denosumab is safer in renal failure. So because denosumab is safer in renal failure, denosumab has also got a lesser risk of osteonecrosis of the jaw compared to bisphosphonates. So when you use denosumab, if you know renal compromise, it is safer, you can directly go in for denosumab. But the catch here is that the question is, which bisphosphonate is safe in renal compromised? And the answer is pamidronate. Pamidronate is the answer. That is option number B. Age of surgery in patients with MEN2 that we already discussed earlier. MEN2 A and B we discussed earlier. This question again, we don't have enough data. Castration sensitive prostate cancer progressed on leuprolide. So then it becomes castration resistant prostate cancer. So if you're saying that it is a metastatic prostate cancer on leuprolide, developed progression, you can definitely add abiraterone, you can add enzalutamide, you can add chemotherapy, you can add the newer molecules like apalutamide, all of those things you can add. The option that they have given here is abiraterone plus steroid. That's a good answer. We don't know the other answer. Basically, it is prostate cancer management. You have to know that thoroughly. Next question again, sort of tricky. They're asking target TSH in high risk men 3. I don't know what they meant really, because men 3 is referring to men 2B basically. So men 2B, you are looking at medullary thyroid cancers. Medullary thyroid cancers, they are not differentiated thyroid cancer, and medullary thyroid cancer patients do not have a TSH target value. You can keep them euthyroid. So this target value of 0.1 is for less than 0.1 is for high risk follicular carcinoma and papillary carcinoma thyroid. Patients with MEN3 means MEN2B, we expect them to have medullary thyroid cancers, and for them there is no target TSH value. The idea is to keep them euthyroid. I think it's a trick question, and because MEN3 means MEN2B and looking at medullary thyroid cancer, and because medullary thyroid cancers don't have a target TSH value, the answer here will be euthyroid. So that's about the questions we have. I'll just do a quick recap of some of the salient features of MEN2 syndrome here. So it of course involves the RET, which is a proto-oncogene. So it involves activation of the proto-oncogene 10q11 chromosome, of course autosomal dominant. MTC, that is medullary thyroid cancer, is almost 100% incidence in MEN2 syndrome. Pheochromocytoma has got around 50% incidence, and primary hyperparathyroidism has got around 20 to 30% incidence. This is, I'm talking primarily about MEN2A. I'm sorry, I didn't mention that. So this is I'm talking about MEN2A. So MEN2 overall is Rett proto-oncogene activation. 10q11 is the chromosome. It has got an autosomal dominant inheritance. Of course, the type of Rett involved or the codon involved is 634. 634. We discussed it earlier. MEN2A, 100% medullary thyroid cancers, 50% pheochromocytomas, 20 to 30% incidence of primary hyperparathyroidism, as we have written here. What about MEN2B? What about MEN2B? MEN2B have got, they're more aggressive, very, very aggressive. The 918T codon involvement of Rett. MTC happens very early, is very aggressive, hence the timing of surgery is ideally before 6 months or at least by 1 year, whereas for MEN2A, the timing of surgery is before 5 years, but for MEN2B, the timing of surgery is before 6 months or at least before 1 year. The other factors, in other things that you see in MEN2B is a pheochromocytoma. You can also have other unique features like mucosal neuromas, marfanoid habitus, and intestinal ganglioneuromas. Okay, so marfanoid habitus, mucosal neuromas, and intestinal ganglioneuromas. These are seen in MEN2B. So MEN2B, a marfanoid feature, mucosal neuromas, ganglioneuromas of the intestine. MEN2B, high, nearly 100% incidence of medullary thyroid cancer, which are very, very, very aggressive, early onset, hence needing early surgery, prophylactic surgery before 6 months or even before 1 year. 918T being the codon involved. It also has got pheochromocytoma has a feature. MEN2B does not cause primary hyperparathyroidism, whereas MEN2A does cause primary hyperparathyroidism in 20 to 30% of individuals. Primary hyperparathyroidism is not a feature of MEN2B. Also, as we mentioned earlier, MEN2B is also called as MEN3. The other thing that comes in the same spectrum is FMTC, or the familial medullary thyroid cancer. It involves only medullary thyroid cancer. There are no other associations. And I think there will also be a short discussion on Lee-Fromeny syndrome. Lee-Fromeny syndrome. So what are the Lee-Fromeny syndrome? Of course, it involves a hereditary mutation in P53 chromosome, P53, which is on chromosome 17p13. It is autosomal dominant. P53 is a tumor suppressor gene. Of course, it is the guardian of the genome. P53 is the guardian of the genome. Of course, hence is a tumor suppressor gene. Around 100% of females with Lee-Fromeny syndrome get cancer. Around 70% of males with Lee-Fromeny syndrome get cancer. Characteristically, these patients can have multiple cancers in the same patient, and of course, significant family history. What are the classical cancers? One is, of course, the soft tissue sarcomas. Especially in kids, it's rhabdomyosarcoma. The other sarcomas being leiomyosarcoma. Of course, there are brain tumors like astrocytoma, glioblastoma, medulloblastoma, and in children, choroid plexus carcinomas, in children. All types of leukemias can happen, especially ALL can happen. Adrenocortical carcinoma, especially in children, especially early onset children, is very, very, very characteristic. So, if they ask for a characteristic tumor of Lee-Fromeny, you will have to go for adrenocortical carcinoma. And of course, early onset breast cancers, more likely to be HER2 positive and more likely to be seen in less than 35 years of age. So, soft tissue sarcomas, adrenocortical carcinomas, brain tumors, leukemias, especially ALL, and early onset breast cancers, which are more likely to be HER2 positive. These are the associations of Lee-Fromeny syndrome. So these are the classical cancers that you mentioned. Which are the other cancers? You can have osteosarcoma, lung cancers, gastrointestinal cancers, pancreatic cancers, skin cancer, mainly melanoma. Leaf-Fromeney syndrome, the skin cancer associated is melanoma, others being pancreas, GI, lung, osteosarcoma, and the other most common cancers, the most common 5 cancers that I described earlier. One classical feature is try and avoid radiation. Radiation is kind of, because there is a P53 problem, any radiation exposure can lead to malignancy. So avoid radiation as part of any treatment is very, very important for Leaf-Fromeney patients. You have to know 2 protocols or 2 criteria. One is the Toronto protocol. So one is the Toronto protocol. Toronto protocol is used for the surveillance of patients with Leaf-Fromeney syndrome. It involves annual whole body MRI, annual brain MRI. It involves annual dermatology examination. It involves annual abdominal USGs. It also involves a colonoscopy by 25 years of age, and also breast MRIs after 20. So start annual colonoscopies by around 25 years of age. After 20 years of age, start annual breast MRI. There should always be annual whole body MRI, annual brain MRI, abdominal USGs, and dermatology examination to look for melanomatous lesion. These are the protocol that you have to use in a patient with Leaf-Fromeney syndrome. That is the Toronto protocol for cancer screening in Leaf-Fromeney syndrome. That is one named thing you have to know. You should also know the COMPRET criteria for the diagnosis, for a clinical diagnosis, clinical diagnostic criteria for patients with Leaf-Fromeney syndrome. I hope you are aware of Toronto protocol and the COMPRET criteria, the clinical features I just described. Please keep that in your mind. So that's all the questions that we have with December 2025 NEET-SS Medical Oncology. Of course, some of the questions have been incomplete. Some questions we could not get, of course. There have been errors in the recall, but then overall, almost all the questions are well covered in our modules. They are being updated every year. So this year also, we will have a lot of updations to our existing module. A lot of new things will be added. Please make use of all of that. Happy learning. If there is anything, please feel free to get back to me. Thank you.